Hi, everyone. Thank you for listening to this webinar. This webinar is focused on how we work up patients with persistent genital arousal disorder or genital pelvic dysesthesia. This webinar is focused on how we do diagnostic testing for these patients. We need to select the correct patient with persistent genital arousal disorder or genital pelvic dysesthesia for corrective, definitive spine surgery if that is appropriate. This webinar is a first. We have not really yet focused on the diagnostic evaluation of persistent genital arousal disorder or genital pelvic dysesthesia patients. From the patient's perspective, diagnostic testing is the key to understanding the best management strategy. From the spine surgeon's perspective, the more highly selected the patient is with a true spine pathology for the genital pelvic dysesthesia or persistent genital arousal disorder, the better the surgical results will be. I always say persistent genital arousal disorder or genital pelvic dysesthesia is a monster condition. Persistent genital arousal disorder or genital pelvic dysesthesia can be caused by over 50 different recognized pathologies. So, accurate, non-invasive diagnostic testing is the key. I want to thank the amazing, awesome, fabulous, incredible spine sexual medicine team. First, of course, is my wife, Sue Goldstein. She's a sexuality educator and researcher. Sue is current president-elect of the International Society for the Study of Women's Sexual Health. Sue is the glue and real liaison between the three groups, San Diego Sexual Medicine, Excel Spine here in San Diego, and Rutgers University in New Jersey. Next member of the team is Dr. Barry Komisaruk. He is the neurophysiological brains behind the spine sexual medicine team. You will see his knowledge embedded between many slides in this talk. Finally, Dr. Joel Kim. He is the caring, passionate, skillful, artist-like surgeon who fixes patients with spine pathology through a 7 millimeter incision. Today, I will talk on the neurologic diagnostic testing in patients with persistent genital arousal disorder or genital pelvic dysesthesia. This talk is divided into 3 sections. Let me spend a few minutes on what is persistent genital arousal disorder or genital pelvic dysesthesia. I will always say persistent genital arousal disorder or genital pelvic dysesthesia is a monster. Please look carefully at this drawing by Lydia F. This drawing is worth 1,000 words. This drawing represents the impact and violation experienced by the artist from her lifelong symptoms of persistent genital arousal disorder or genital pelvic dysesthesia. Persistent genital arousal disorder or genital pelvic dysesthesia is highly associated with depression, unhappiness, shame, worry, and suicidal ideation. It was a suicide more than 5 years ago, Leah P. from Denmark, that was the motivation that allowed us to start the spine sexual medicine program here in San Diego and Rutgers University. Okay, take a deep breath and not be overwhelmed. It is my job today to teach you. This next slide depicts on the left the somatosensory cortex of the brain, where the brain processes sensory information from the entire body. Say 7 o'clock of this slide shows the tongue, 9 o'clock shows the lips, 10 o'clock shows the hand, 11 o'clock shows the elbow. Specifically, in the rectangle on the upper right, that is the paracentral lobule. This is the region in the brain that processes sensory information from sacral nerve roots S1, S2, S3, S4. This includes information from the lower extremities, genital region, bladder region, rectal region. Persistent genital arousal disorder or genital pelvic dysesthesia is considered to exist if patient symptoms include persistent or recurrent, unwanted or intrusive, distressing sensations of genital arousal for more than 3 months. It may include other types of genital pelvic dysesthesia symptoms: buzzing, tingling, burning, twitching, itch, pain, other than arousal. Most commonly experienced location of the symptoms is the genital, clitoris or penis, but also could be in other genital pelvic regions such as mons pubis, vulva, vestibule, vagina, scrotum, urethra, perineal region, bladder, and or rectum. Again, I'll repeat, the paracentral lobule represents in the brain where sacral roots S1, 2, 3, and 4 are processed. Okay, this next slide is my favorite slide. Again, thank you, Dr. Barry Komisarek, for your amazing research. In the lower middle, in the red rectangle, or in the upper left, in the red circle, is the paracentral lobule, again representing the region of the brain processing sensory activity of sacral nerve roots S1, S2, S3, S4. Now, in the upper middle, fMRI, Functional Magnetic Resonance Imaging Study, this is Dr. Komisarek's research. The woman was voluntarily asked to touch her clitoris and record the activity in the paracentral lobule. Can you see that? It's about the size of an olive and it's red. Now, contrast that to the upper right functional magnetic resonance imaging, fMRI. This is a woman having a PGAD episode. Look at the severe, spontaneous, she wasn't asked to do this, intense activity in the paracentral lobule that occurs without the patient's permission. It is not voluntary and it is unwanted. This is the reason why persistent genital arousal disorder or genital pelvic dysesthesia is a monster. Comparing the size of the olive to the size of, let's say, a grapefruit, that is unbelievable, unwanted, intense activity in the paracentral lobule. Okay, this next slide is my second favorite slide. Again, thank you, Dr. Komisarek, for all your research. If persistent genital arousal represents unwanted, severe, spontaneous, intense activation of the paracentral lobule without the patient's permission, those are the two fMRIs, and that's the one on the right, showing the intense activation. Then let's look at the bottom of the slide. Where is the trigger coming from? So if we can find the trigger and locate it, we can best manage the condition. An expert panel convened and consents to divide the highway of sensory information from the genital lower extremity region all the way up to the paracentral lobule in the brain into 5 regions. The first region, the one on the left, is the end organ. This consists of the genitals, most commonly, also the bladder and rectum, and also the lower extremities. Region 2 is the sort of highway between the end organ and the beginning of the spine. That's the pelvis and perineum. It involves the pudendal nerve in particular. Region 3 is the bottom of the spine called the cauda equina. The genuine spine is region 4. That starts at T12 and at the conus medullaris. And region 5 is the brain. This consent ability to divide the highway into 5 regions has been extremely helpful. We have now discussed persistent genital arousal disorder or genital pelvic dysesthesia. We now recognize its unwanted, spontaneous, intense activity in the paracentral lobule coming from somewhere, region 1, region 2, region 3, region 4, or region 5. Now, why do we do neurogenital testing? This next slide discusses the why. Neurogenital testing is not invasive. Neurogenital testing assesses the integrity of sacral nerves from the genital region and the non-genital lower extremity region. If a patient with persistent genital arousal or genital pelvic dysesthesia has a history consistent with cauda equina pathology, such as low back pain, car accident, fall downstairs, fall onto coccyx, fall while skating onto the buttock area, dysesthesia or weird or unusual feelings in the lower extremities, buttocks region, posterior thigh region, posterior calf region. History of sciatica, the pinched nerve that involves referral pain down a leg or both legs. These patients should consider undergoing both non-invasive testing with lumbosacral MRI and neurogenital testing. These non-invasive tests should be performed prior to more invasive tests, such as transforaminal epidural spinal injection. This latter test involves a sterile procedure, a highly specialized provider, fluoroscopy, sedation, and epidural injection. In summary, non-invasive testing should precede more invasive testing. This next slide is the management algorithm for patients with a history consistent with persistent genital arousal disorder or genital pelvic dysesthesia. Let's go through this rectangle by rectangle, starting from the top to the bottom. The first rectangle is the history consistent with the disorder, unwanted, intrusive symptoms of unwanted arousal or dysesthesias, burning, itching, pain, etc. The second rectangle is a history consistent with cauda equina pathology. We've already discussed this also. Low back pain, car accident, falls onto the coccyx region, weird or unusual feelings in the buttock region, posterior thigh region, posterior calf region, history of sciatica. Now, the next two rectangle lines are marked with a red rectangle. These are your non-invasive diagnostic tests. Now, you can start on the left with the lumbosacral MRI and then do neurogenital testing, or you can start on the right, starting with neurogenital testing and then getting a lumbosacral MRI. The order of those two tests is not that relevant. Finally, based on the results of the non-invasive testing, then the second to last rectangle is undergoing the transforaminal epidural spinal injection for lumbar pathology or the caudal epidural for sacral pathology. And then finally, if everybody passes the tests and they're all positive, then spine surgery could be considered. This next slide is real important, and there's lots of information on it, so we will go slow. The upper image shows green nerves that are part of the sciatic nerve, and yellow nerves, which are part of the pudendal nerve, serving the genital. The sciatic serves the lower extremity, the pudendal serves the genital region. So you can see underneath the picture of an individual looking at the posterior aspect. You can see the gluteal region, the posterior thigh region, posterior calf region. These are represented by the sciatic nerve, which roots are S1, S2, S3, S4. And just to the pudendal region, that's serving roots S2, S3, S4, and they pass on the pudendal. You can see for the oval in red, which says S1, S2, S3, S4, that is the region served, as we've discussed, and processed in the brain in the paracentral lobule. Now, the nerve roots, when they enter, we're now going to look in the upper right picture. You're going to see the nerve roots of S4, S3, S2, S1 enter the cauda equina. And then in their highway to the paracentral lobule, they pass through the lumbar region. So lumbar pathology, such as depicted in this picture, an L4-5 annular tear, the nerve roots from S4, S3, S2, S1 have to pass through the annular tear. Now, the lower pictures will pinch the sort of end view. This next, you can see the annulus as the circular fibers protecting the inside, which is the nucleus. Above the annulus, you can see the epidural space. The epidural space is surrounded by the dura, and you can see the sort of end view of all the nerves in the cauda equina. Now, the picture on the right shows a break within the annulus called an annular tear. The nucleus extrudes into the epidural space, impinges, and mechanically and inflammatory-wise irritates the nerves within the cauda equina, causing them to fire and result in unwanted, intrusive information passing from this annular tear irritation up to the paracentral lobule, resulting in the persistent genital arousal disorder or genital pelvic dysesthesia symptoms. So in summary, information from the genitals and the sciatic nerve, which passes through the sacral roots, has to pass into the cauda through the lumbar area. If there's pathology in the lumbar area, it can irritate the nerve, and this would be a region 3 pathology that's causing the persistent genital arousal or genital pelvic dysesthesia symptoms. Okay, this slide summarizes the just 3 non-invasive tests for neurogenital testing. Why do we have 3 non-invasive tests? Again, just to reiterate, the sacral nerve roots, S1, S2, S3, S4, emanate from the genital region through the pudendal nerve, S2, S3, and S4, but also from the lower extremities, the sciatic nerve, S1, S2, S3, S4. So non-invasive testing for neurologic integrity has to involve both the lower extremities and the genitals. So the 3 tests are called the non-genital sacral dermatome test, which assesses the integrity of sacral nerves from the buttock, posterior thigh, and posterior calf region. And then the genital quantitative sensory testing, which assesses vibration, hot, and cold sensory information from the genitals. And then the bubble cavernosus reflex latency test, which tests the nerve roots S2, S3, and S4. And this involves a reflex where information passes from the genitals into the lower spine at the conus medullaris, and then passes downward through the cauda equina out to the motor nerves, causing the pelvic floor muscles to contract, in particular, the external anal sphincter to contract. This next slide summarizes the 3 non-invasive tests involved in neurogenital testing. In the box on the left, number 1 is the quantitative sensory testing, which does vibration, hot and cold of the genitals. Test number 2 is sacral and foot dermatome testing, which measures the nerve integrity of the lower extremities involving the buttock area, gluteal area, the posterior thigh area, and the posterior calf area of feet. And then the 3rd test is the bubble cavernosus reflex, which assesses the reflex latency from tapping the genital to motor contraction in the external anal sphincter region. You can see pictures. Test 1, you can see vibration of the genital, and another box shows, another photo shows hot and cold of the genital, and you can see the picture in number 2, you can see vibration in the gluteal area. In number 3, you can see tapping of the genital area with subsequent measurement of the motor activity in the external sphincter region. And you can see on the bottom part of the slide the 5 regions. So based on these 3 non-invasive tests, there are signature results which identify the location of the trigger that's resulting in a persistent genital arousal. And we'll show that in the next slide. This next slide shows how neurogenital testing can identify the region. Region 1, end organ. Region 2, the pelvis perineum. Region 3, the cauda equina. Region 4, the spinal cord. Or Region 5, the brain. You can see in the description, you can see actually in the rectangle that's red, for the cauda equina, where we commonly see patients who have triggers for persistent genital arousal or genital pelvic dysesthesia. The genital quantitative sensory testing would be abnormal. This involves information passing from the genital to the paracentral lobule. If there's pathology in the cauda equina, such as an L4-5 annular tear, that test will be abnormal. The non-genital sacral dermatome testing would also be abnormal because the annular tears, say an L4, L5, will interfere with sciatic nerve information from the lower extremities passing to the paracentral lobule. And the bubble cavernosus reflex latency testing will be abnormal because, again, tapping the genital and measuring activity that goes through the cauda equina up to the conus medullaris, or the bottom part of the spine, would also be abnormal. Now, if we look at regions 1 and 2, the genital sensory testing would be abnormal. Again, the information from the genital to the paracentral lobule that passes through, let's say, a pudendal nerve problem, that would be abnormal. But the non-genital sacrodermatome testing, which has nothing to do with the pudendal nerve, has only to do with the sciatic nerve, that would be normal. So the signature here would be that if the sacrodermatome testing were normal, but the genital quantitative sensory testing would be abnormal, and of course the bulbar cavernosus reflex would also be abnormal, that would signal regions 1 and region 2. Finally, if you look at regions 4 and 5, and region 4 is the spinal cord above the conus medullaris, the bulbar cavernosus reflex will be normal because information only gets to the lowest part of the spine in that test. So again, the neurogenital testing has the ability in a non-invasive way to identify the region that's triggering the persistent genital arousal disorder or genitopelvic dysesthesia. Well, thank you for listening. We're now up to the bottom part of the talk, the summary. So, in summary, we've developed neurogenital testing to assess the integrity of genital and non-genital sacral nerves. Now, based on the finding of abnormal results of the 3 neurogenital tests, and abnormal treatable spinal abnormalities on MRI, and absence of pathology in regions 1 and region 2, and having a positive transforaminal epidural spinal injection, spine surgery can be successfully applied in these highly selected patients. That should result in significant symptom relief in some patients who have caudate equina pathology as the basis of their persistent genital arousal disorder or genitopelvic dysesthesia. Okay, this is the final slide of the talk, and thank you so much for listening. This is an important slide, and we'll try to spend a few seconds on this slide. In conclusion, neurogenital testing is non-invasive. Neurogenital testing assesses integrity of sacral, genital, and non-genital nerves. Pathologies within the caudate equina, a lumbar annular tear, lumbar herniated nucleus pulposus, or sacral tarlous cyst, are an example of caudate equina pathologies. These pathologies could irritate and stimulate the sacrospinal nerve roots within the caudate equina, thereby conveying unwanted, intense, abnormal sensory activity from region 3 to the paracentral lobule. This could lead to persistent genital arousal disorder or genitopelvic dysesthesia. Now, this is important. Caudate equina pathologies are upstream from the genital where the symptoms are occurring. Caudate equina pathologies are remote from the location of the perceived problem, the genital and non-genital regions that cause the persistent genital arousal disorder or genitopelvic dysesthesia symptoms. So here's the point. Since sciatica, we all understand sciatica, is a condition where pain is perceived to originate from the leg, but in reality it doesn't originate from the leg. It results from irritation of nerve roots in the caudate equina that is upstream of the entry of the roots into the sacrum. Therefore, final drum roll situation. Persistent genital arousal or genitopelvic dysesthesia may be a condition where the symptoms are perceived to originate in the genitals, but in reality results from irritation of nerve roots in the caudate equina upstream of the entry into the sacrum. We therefore may consider clinically persistent genital arousal disorder or genitopelvic dysesthesia as a genital sciatica. Maybe if we called it a genital sciatica to our colleagues and to our patients, more people would understand. Again, thank you so very much for listening.